residency from University of Maryland. His main focus is in clinical trial, with a special interest in a multi-center international studies and community health research. His 83 indexed publication including international publications covered many areas in clinical and epidemiological research. Currently, he is a chairperson of Research Monitoring Department and head of Research Business and Strategy Development section of King Fahd Medical City Research Center at Riyadh in Saudi Arabia. And he is an active member at KFMC IRB since 2008. After you choose your mentor, you choose your question and hypothesis. You did some literature review and you read the medical literature. So what is the next step? I think the next step is to choose your design. If you like to know how to choose your design, please join me in welcoming Dr. Mohammed Al-Tanir and deep dive with him into study design in medical research. Welcome, Dr. Mohammed Al-Tanir.
Thank you so much, Dr. Dunia. I'm really happy to be with you today, and I hope that everyone will get the benefit aiming from this course. So let's start. I want to put it full screen. Can you see my screen? Can you hear me?
Yes, Dr. Mohammed, we can hear you. And we can see your slides.
So let's start our journey in study design in medical research. We all know that the goal of clinical research is generally to draw inferences from the study results of a sample about the nature of the truth in the universe. So whatever, as you know, in every study, we select a representative sample to do our research on. The findings of this study, we make inferences from these results to really generate the truth in the universe. We all also know that research pathway has three main stages. Stage one is the question stage that is built on the research idea and how to formulate it in a research question. Stage two is the research proposal that usually is written for two main purposes. One, to really obtain IRB approval before conducting any research or start collecting data, and other purpose also to really apply for grant for research, because as we all know that research needs money and time. So this applying for a research fund is really an essential issue in research conduct. And stage three is publication. Nothing is considered complete in research if we do not publish what we really search for. So designing, as I said, we start with our well-formulated research question that's supposed to be answerable and feasible. Very interesting. I stress on the word feasible. Feasibility in research is really important because I might come with the best research question ever, but it's not feasible to conduct this research question in my daily routine work environment. So once I select my research question, it comes the role of study design. I have to really pick or select the best study design that answer my research question. Study design is not a menu that it's up to me to select the always to be like randomized clinical trial. Sometimes just by like chart review, I can answer my research questions. So it's very important to select the best study design that well fit and perfectly answers my research question. After selecting my study design, I have to put my study plan. That usually it's well viewed or well established in the study proposal. And I have to implement everything in my study proposal in my actual study. Once I collect my data and analyze my data, these are the findings of my study. So I start making inferences. First of all, I make internal validity. Internal, like inference one will really fulfill the internal validity. What do I mean by internal validity? That means the study population that I collect my data from, really I can reflect the result to the source population from where I pick up my patients. Like if I pick my patients from King Fahd Medical City diabetes clinics, so that I will pick a sample from patients presenting to this clinic. So internal validity is the validity of my result to the source population from where I pick my participant in my study population. Then I want, and this will really like justify the validity of the findings of my study. Then I will move to level 2 of validity, what we call external validity. And that means I want to generalize my findings to the general population, and that's what we call truth in the universe. So drawing conclusions from my study is really very important, and like follow the path from research question to publication involving internal validity and external validity of my findings. I have two types of research: quantitative research and qualitative research. Quantitative research is research that is based on data, on numbers, on measurements. That's why it's very important whenever I decide to conduct a research to know the basics of biostatistics, to know the basics of epidemiology measurements, and to know also the appropriateness of selecting the best study design to answer my research question. So quantitative research, like test theory, hypothesis, what's my aim, what I want to compare. I need to have well-defined variables. It's usually done on a large sample, standardized instruments and variables, and it should really reduce to what I want to really test. Qualitative research, I need to build research. It's just description. Usually it's done on very few people, small sample. It's done by interviews or observation, and on the contrary, it's inductive. How do I choose
Dr. Tanir, sorry for interruption, but your voice is not clear. Can you be close to the mic?
Yeah, sure.
Thank you. Thank you.
How it is now better?
Yes, thank you.
Good. Sorry about that. So how do I choose my design? My choice of design depends on many factors. Depends, as I just said, on my research question, depends on the researcher's skills, experience, and capability, depends on the time and money. So really, if I am really interested in conducting an observational cohort prospective study, that needs time and money. So if I do not have the available funds, so I might change my cohort prospective to cohort retrospective to save some money. occurrence of disease. So once my disease is rare, I do not think about cohort prospective, but I rather think about cohort retrospective or case control study design. Also, duration of latent period and nature and availability of information are two factors that really affect the selection of my study design. Here is my research pathway that usually we have to keep in mind whenever I start conducting my study. I have to define my research question that comes from my research idea, conduct the literature review in order. If I found that there is no hole in the literature, so I have to really refine my research question in order to come up with something new. This is very important. Always think before starting your research, what is the rationale behind conducting this research? In other words, that means what is your research is going to add to the current body of literature, to what is already published. You have to answer, and you have to have an answer for this. Do repetitive research, copy-paste research is not considered the research and is not really worthy to be published, and you will really hassle in publishing a research that will not add anything to you to the body of literature. So always think about and keep yourself ready to answer that my rationale behind my study is going to add such and such, is going to overcome the deficiencies in previous study, and so on. So once your research question is refined, you have to really operationalize your variables. And here it comes after you find your variable, you have to really specify your study design, decide on what study design is going to answer your question, then submit your proposal to IRB to get IRB approval, and then you will start collecting, analyzing your data, and finishing but the manuscript. So always in your methods, whenever you write your proposal, you have to really well specify who will be studied, define your study population, your participants. You have to define your cases, what disease they should have, what treatment are they taking, who will be excluded, what are the inclusion-exclusion criteria. Very important to specify your sample size. Sample size is very important to be well calculated and justified from the beginning. How they will be studied, who will collect the data, what you will measure, how they will be measured, who will take this measurement. So all the WH questions should be really described in a comprehensive way in your method section in your proposal, and you should follow them strictly. And this is one of the major differences between clinical practice and research practice. In clinical practice, you might really practice your like treatment in a bit different way between patients according to different factors. But in research, you have to strictly follow your proposal, and you cannot really deviate from your proposal. And if you feel yourself you need to do it, you have to justify it, and it should be for the benefit of overall health of your participants. So also in your proposal, you have to state what obstacles might prevent complete success. You have to talk about the recruitment process, safety issues, interim analysis, loss to follow up if it's a prospective study or interventional study, good quality data, and how can they be minimized. I mean, how this barriers can be or obstacle can be minimized, taking into account confounders and biases issues. So study design, as you see, whenever we decide how this will be studied, you have to select the best study design that fits your research question. Let's talk about study design in quantitative research in details. This taxonomy of quantitative research is very important. And let me tell you a thing, if you leave my presentation today and only you understand this taxonomy perfectly, for me, this is more than enough. So this is very important because it's very essential to understand the study design if you are reading a literature or if you are conducting a research. So I simplify it in a very nice way. Let's take me as investigator. Am I assigning exposure? Like, am I assigning participant in the study to the exposure to yes or no? If no, so this is completely an observational study. If yes, if I assign patient A, participant 1 to the group A and participant 2 to group B and so on, so I'm intervening here. So that's what we call interventional study. If I'm not getting involved, I'm just observing and keeping my arms crossed, so I'm just observing. If it is observational study and I'm not getting involved, I have two options. If I have a comparison group in my observation, if I'm comparing the two groups, one who is exposed versus one who is not exposed, this kind of study, I call it analytical study. If I'm observing only one group without comparison group, this is what we call descriptive study. So descriptive study is any study design, is any observational study design with one group, while analytical study is any observational design that have two groups, one exposed and one non-exposed. In the analytical study could take three directions. One, cohort study. Two, case control study. And three, cross-sectional study. Let's talk about each in detail later on, but I will tell you just keywords for each of the three subcategories of the analytical study. Cohort study, I select the participants in my study based on the risk factor or the exposure, like smoker, not smoker, and I want to see if they do develop cardiac disease, yes or no. So once I select my participants based on the risk factor or the exposure, this study design is a cohort observational study design. Retrospective and prospective are not, some people use them as study design. These are not study design. These are just adjectives that describe the time I collect my data. If I want to follow up from present to future, once I collect my data on my participant, this is what I collect prospective cohort. If I want to go back to their files and see their data, look at their data in the past, like I initiate my study now in the present, but I look into the past or history of my participant, this study design is cohort, a retrospective cohort observational study design. What about case control? Case control, it's really fits rare disease. I select my participants based on their disease status. Like leukemia patient, no leukemia patient, a healthy participant. Leukemia patient versus a healthy participant, and I will look into the risk factor that might contribute to the occurrence of this leukemia. So I select my patients based on their disease status, not on the exposure like I did in the cohort. The third kind is cross-sectional study, or what is known like more as like questionnaire or survey. What I do, I collect my exposure and outcome at the same time. And that's why we call it cross-sectional, because exposure and outcome cross at the same time of data collection. So I'm not really sure if the exposure precedes outcome or not. So these are the three types of analytical observational study. What about if the investigator or the researcher intervene in allocating the participants to experimental or to interventional or control group? So we call this interventional study, and usually in most of cases is randomized. If it's randomized, we call it randomized controlled interventional trial. Or if it's not randomized, people are collecting on like a consecutive patient presenting to my clinic or my hospital. We call it non-randomized controlled trial. Clear? Good. We will talk in details about each of these study designs. So descriptive studies are observational studies that have one group. They do not have a control group, a comparison group. So this descriptive study is concerned with and designed only to describe the existing distribution of variable without regard to causal or other hypotheses. We have individual descriptive study or population descriptive study. Individual could be on one participant, and we call it case report, or it could be on several patients, and we call it case series. Once it includes the entire population, the descriptive study is called ecologic study. So this is an example of a case report, atypical trigeminal neuralgia associated with tongue piercing. A patient presenting with a tongue piercing, and he presented with trigeminal neuralgia. So this is, we describe in details this case, and we call it a case report descriptive observational study. Like case series, as I said, it could exceeds one patient. We call it case series, and it can go from 2 up to 10s. So case series has no comparison group and can goes from 2 up to 10s. So like here, the example is botulism in 4 adults following cosmetic injections with concentrated botulinum preparation. Surveillance study, this is what we call ecologic study. Like you take the entire population and you see what is the distribution or the usage of the population of specific factors you want to study. So it's exposure data for population and outcome data for population. Now, as I said, I repeat what we talked about analytical research. I repeat it because it's really important to really catch up. Observational design, as I said, it includes in the analytical cohort, case control, and cross-sectional, while the interventional study have only randomized and non-randomized studies. Let's take an example. This is exposure and outcome. Exposure is high cholesterol, the outcome is atherosclerosis. Exposure is atherosclerosis, the outcome is cardiac artery disease. Cardiac artery disease, myocardial infarction, aspirin with myocardial infarction. So all this that you have here as examples are the exposure, and here the outcome. You as a researcher, you are the one who specify what the exposure is, the factor of interest that you are interested to study, and you specify also your primary outcome of the study. This is very important because according to the specification of the primary outcome, the statistician will help you how to really calculate the needed sample size in order to really apply the appropriate statistical test with significance level. So this is another example, statin use. We want to see in a cohort study. We start with statin use and we want to see the effect on myocardial infarction. So this is statin use, the exposure, and the disease is my MI. This is a cohort study because we select our participant based on their exposure status. When we select our patient based on the disease status like MI, and we want to see if they used to use statins, so the study design will become case control study. So cross-section study, as I said, exposure and outcome are collected at the same time. That's why we call it a cross-sectional study. So cohort study is a group of cases followed over time, could be from present to future or from present to past. The example, investigator examining a cohort of patients yearly for several years, observing the incidence of heart attacks in statin users and non-users. So exposure could be present or absent, exposed, non-exposed, developing the disease, yes or no. This is the chart of the cohort study design. As I said, prospective and retrospective are not a study design, are just adjective to describe the data collection of a specific study design specifically used for cohort study. But a case control study could be also prospective or retrospective. This is like, as you see, prospective cohort, you see present going into future. Retrospective, starting in the present and going back to the past. Retrospective cohort. So what are the strengths of cohort and what are the weaknesses of this study design? The cohort study will allow me to measure the incidence of disease because, you know, whenever the incidence is a number of new cases of disease divided by total population at risk. Whenever I want to study incidence, I want to screen my participants and make sure that they do not have the disease once I want to start enrolling them in the study. And I will follow up with them for a specific period of time according to my research question. So this is the only study design that allow me to measure the incidence of a disease, cohort prospective study. So it could also allow me to investigate multiple outcomes, study rare exposure, and it will really provide me with the temporal sequences. So it could really provide me with causality, that this exposure caused this disease. Weaknesses, we have a selection bias. It's expensive because it needs time and effort and the team. It's not really suitable for rare disease, requires large sample size, and I could really face loss to follow up during if the follow-up time is long. Cross-sectional study is the best study design that fits my prevalence study. If I want to study prevalence of a disease, the cross-sectional study is the best. Like example, examining a group of patients, once observing the prevalence of history of MI in statin users and non-users. So as we said, it's done at one point of time. I study exposed and non-exposed at the same time to see who will develop disease or not. Cross-sectional study strengths is not expensive, quick, and it's the best that, as I said, for prevalence purpose. Weakness, I cannot establish a sequence of events like causality factor in cross-sectional, not feasible for rare exposure or outcome, and I cannot also measure the incidence or true relative risk of any exposure and the outcome. Case control study, as I said, it's the best fit for rare diseases. And sampling is based on the outcome, on the disease status, and then comparing prevalence of exposures in both groups. Example, examining a group of patients with MI as cases and compare them with a group of non-MI as control and track statin use in both groups to see if it's correlated with the disease or not by calculating the what we call odds ratio, that is a substitute for the relative risk. So as you see, present, this is the sample of cases. It should be based on their disease, on their outcome, and we investigate to see if they were exposed or not. And it could be, as I said, to the into past or future. Same thing for the controls. They do not, these are healthy. Controls usually are healthy because they do not have the disease. And we will see if they were exposed or not to see, to really, to be able to measure the odds ratio and the strength association, or the strength of the association between disease and exposure. This is the same thing in another scheme. Biased cases, new cases of the disease that we have no medical attention. This is new cases of the disease seen elsewhere, undiagnosed or misdiagnosed, death or remission before diagnosis. So the cases available for case control studies could be biased, and that's are the main factor that establish biased cases in my case control study. Biased control, the control selection is very hard because I'm supposed to select the control same as patient, but the only difference that they do not have the disease, that they have to be from same gender, same medical history, same age, same socioeconomic factors, and educational level and so on. So it's sometimes it could be very suitable.
Dr. Tanir, we couldn't hear you. I think sometimes when you are using the mouse, you put your
I put my hand
on
over the mic. Yeah, now I get attention.
okay.
Sorry about
Now
that.
it's good. Now it's good. Thank you, and sorry for interruption.
No, it's okay. Thank you for telling me. Sorry about that. Selection bias also what seriously reduce the estimate of effects, the odds ratio. When I select my controls, when I have selection bias in selecting my controls or my cases, I'm really doing a selection bias that will really affect the validity of my results. The controls should be, as I said, free of the outcome of interest, representative of the population at risk of the outcome, and selected independent of the exposure of interest. The strengths are very useful for studying rare disease, short duration, inexpensive, and are very helpful in outbreaks, like could be like helpful study design to study like a COVID-19 pandemic now. Weaknesses, potential, as I said, for biases and confounding, does not establish the sequence of event. Potential survivor bias does not yield prevalence or incidence. It just gives me like estimate of relative odds ratio that it's like a substitute for relative risk. Now we will talk about randomized controlled trial. In a randomized controlled trial, we have mainly two groups created by a random process, randomly assign patient to receive, for example, statins or placebo, then follow them both for several years to observe the incidence of heart attacks in these two groups. Randomized trial as we said, we give one the study or the interventional treatment, and the other one, control group, will take the routine conventional treatment, and we will see how much better the morbidity and morbility in both groups are done. Like we always with our alternative hypothesis is like we want to prove that the study group has a lower morbidity, lower mortality. So it's always essential to specify the primary outcome in order to see what we want to put as future endpoints of the study. We take the example again of statin versus MI, control another kind of old statin versus MI or not MI, and we will see the effect of the new drug versus routine conventional drug. What are the key elements in randomized clinical trial? Like we have to really do a very transparent sampling eligible patients. So I have to respect my inclusion-exclusion criteria very well in order to avoid selection bias. And also I have to generate my allocation in order to reduce confounding by indication, allocation concealment to also to avoid selection bias, blinding in order to avoid performance bias and measurement bias, performance bias by the investigator in order to not be biased to the study group, which the investigator wants to prove its effectiveness, and measurement bias by being really transparent and neutral toward the participant of both groups. Adequate follow-up. The major bias in interventional study in randomized clinical trial is lost to follow-up whenever the treatment phase or the follow-up phase is long. So some participants do not show up or are not really any more motivated to come just for research follow-up visits. And this is really very important issue. That's why it's a big responsibility on us as clinicians, researchers, to really spread the research culture among our patients and our institutions. What are the benefits of randomization? It eliminates bias in treatment assignments before and after enrollment. On average, whenever we do randomization, it provides balance on factors other than intervention. I mean here, a demographic variable that could influence the outcome, which some are known and unknown factors. And also randomization facilitates blinding of participants, investigators, and assessors. This is very important, that neither the participants nor the investigators or data collectors should know to which group the participants belong in order to keep the data protected from bias. Permits use of probabilities theory. So all these four advantages are the benefits of randomization. Blinding is simply hiding who gets what. So it could be single blinded, double blinded, and triple blinded. As I said, the best is triple blinded, as we just said. Neither the data collector nor the investigator or the primary physician nor the participant know to which group they belong. So, but sometimes due to the treatment act, like surgical act or specific medical act, we could not be blind. The data collectors could not be blinded, or a participant or the physician. So sometimes we found ourselves forced to conduct the study which is only single blinded or so on. So how to blind? Usually by using placebo or double dummy. We'll talk about it. And sometimes we are really, when we compare two surgical acts, laparoscopic versus open surgery, it's not possible to be blinded. So that's what we call open label randomized clinical trial, because blinding is unethical or not feasible. Intervention has specific effects or side effects, so that's what really do not allow us to have blinded clinical trials. So this is a double-blind, double dummy. Usually in order, once we are comparing the effect of like two drugs, one used as a study drug and the other as control drug, we use the active tablet with a placebo capsule. And in the group 2, we use the active capsule with the placebo tablet. And in this case, neither the physician nor the participant or the patient knows to which groups it belongs in order to avoid all kinds of biases. So overlap in the conceptual basis of quantitative study design. The cross-section, these are very important tips that I choose to tell you about. Cross-section study can be repeated. If I want to really study the prevalence of migraine among like university students in fall 2021, I can repeat it again in like winter or the following fall. So cross-section studies could be repeated. If the same sample is studied for a second time, it is followed up. The original cross-section study now becomes a cohort study. This is also a very important and interesting tip. If you are doing cross-section study on the same participants on a different time period, let's say September 2021, and then you do it on April 2022, that second study will be considered as cohort study, because you follow up with them over 6 months or so on, and this study will be considered as prospective cohort study. If during a cohort study, possibly in subgroup, the investigator imposes an intervention, a trial begins. If you are just doing an observational prospective cohort study, and for any medical reason, you want to select specific patients from this cohort observation group and intervene on them, then what you do now, you are imposes an intervention, a trial begins on this subgroup that you took. A cohort study also gives birth to case control study, using incident cases, nested cases control study. Let's say you are comparing an exposed group versus non-exposed group, and you found that in the exposed group there is something unexpected that you noticed as researcher, and you want to go back with this, only with this exposed group, to study a specific factor that comes to your curiosity or to the benefit of your research. This subgroup that you really extracted from the exposed group of your cohort study will be considered as a new study and called nested case control study. Cases in case series, particularly a population-based one, may be the starting point of a case control study or a trial. And this is really very applicable in a clinical trial. Usually, in like a pilot study of a clinical trial, you take few patients and you really apply the new technique or the new drug of them. So you take a group of 10 or 5 and you apply, and you see the effect of this drug or surgical technique on them, or whatever your study question is. So always case series could be the nucleus of a future clinical trial or case control study. Not every epidemiological study fits neatly into one of the basic designs. Sometimes we could have a combined study design. We could have like retrospective cohort observational study Then in the middle of the study, we switched to prospective cohort study design. These are the class of evidence with the study design. We all know that the best study design with the highest class of evidence are good quality randomized controlled trial that should possess adequate random assigned methods, similar groups at baseline, adequate sample size, follow-up at rate of 85% or more, and maintenance of comparable group. So whenever I have a good quality randomized controlled trial, I have the class of evidence 1. If I have moderate quality of randomized clinical trial, the class of evidence drop to 2, which is equal to good quality cohort study. If I have a good quality cohort study, it's class of evidence 2. If I have also good quality of case control study, I consider it evidence 2. If I have poor quality randomized clinical trial or moderate or poor quality cohort, it is class 3. If a good cross-sectional study is also a class 3 level of evidence. So what is the challenge in study design, or what's the challenge in general in conducting research? Is really to do an appropriate designing and implementation. Whenever I have a well-formulated research question, I have to select the best study design that suits this research question in order to really avoid any random and systematic error. Random and systematic error is the definition of bias. And also, avoiding biases is by implementing, as I told you, exactly and strictly following the proposal and the inclusion-exclusion criteria, the measurement, measuring the variables exactly by the same way, by conducting standardized session. Not every data collector should collect the data in his way or her way. There's supposed to be standardized way to collect data. So these two stages, study design, or these two issues, study design and implementing the study plan, are the two major issues that affect internal validity and external validity. And as you see, bad selection of study design is the essential factor in affecting external validity and to transfer the truth from my study to the truth in the universe. So this is very important issue. So the challenge in selecting the best study design and implement the study as with adequate control over bias and random error. Let's talk a bit for a few minutes before ending about bias. Bias is a systematic departure from truth due to design or measurement. That's why if we look back here, so biases are due either to design or to measurement. Measurement means implementing the study plan by collecting the data. So biases versus chance. Is bias same as chance? No. As you see, bias, like let's take here number of observation. Once we are measuring the blood pressure, if this is here, if I'm using the sphygmomanometer, the values here that right and left of the true value, these values are only due to chance. But if I'm using another different device totally, intra-arterial cannula, the value I obtain here is due to bias because I have different measurement, different device measurement. So the values here are due to chance, but the value between intra-arterial and sphygmomanometer is due to bias because I did not standardize my measurement devices. Types of bias, I have selection bias, measurement bias, recall bias. What is selection bias? It occurs when recruitment processes lead to a sample that systematically differs from the target population in important characteristics. This happens when we do not respect exclusively or appropriately inclusion-exclusion criteria of my study design, of my study proposal. Measurement bias when we are not using the same standardized way of measuring variables on my participants. This is the same example I just Now let's talk, is bias a serious issue? Yeah. Is bias, I can really like compensate, it's irreversible. Unfortunately, biases are irreversible. Confounding is less serious than biases. A confounder is a variable associated with the exposure and it affects the outcome, but it's not in the causal pathway between exposure and outcome. This is very important. It's associated to both exposure and affect the outcome, but it must not or should not be in the causal pathway between exposure and outcome. So it is associated with the exposure and it affects the outcome, but it's not in the causal pathway. Let's take example. Smoking is associated with coffee. Usually people who smoke drink coffee and vice versa. So it's associated, coffee and smoking. Smoking affects MI, but smoking is not in the causal pathway between coffee and MI. So if we study the effect of coffee on MI without studying or taking into consideration the status of my patients on their smoking status, so I'm really here doing a confounder. Smoking will be considered as a confounder factor between coffee and MI. High cholesterol and MI. Atherosclerosis is not associated, is in the causal pathway between high cholesterol and MI. So atherosclerosis is not a confounder factor because it is in the causal pathway between cholesterol, high cholesterol and MI. So best study design depends on the hypothesis being tested. As I said, a research question could be answered by cross-section. If I'm studying the prevalence of a disease, so a cross-sectional study design fits. If I'm studying the effectiveness of drug A versus drug B, an interventional study is the best study design. If I'm studying the risk factor of cancer, of specific cancer patients, case control study because it's a rare disease, it's the best study design. If I'm studying the effect of smoking or the effect of fluoride toothpaste on dental cavities, the best study design is a prospective cohort study. So this is hypothesis or research question really is essential in deciding what study design to select. Minimize the best study design, as we said, it minimizes biases and confounding, and then leverage it will help to leverage the level of evidence. The study design should always be ethical and feasible. This is very interesting. Ethical and feasible are basic that we cannot omit or ignore. So type of question and suggested study design for therapy is randomized clinical trial. For etiology is randomized clinical trial, then followed by cohort, case control, or case series. For prognosis, its cohort study is the best study design, followed by case control or case series. Prevention, also for prevention, is the same as therapy, and etiology, it should be randomized clinical trial. For diagnosis, it will be prospective and blind comparison. It will be the gold standard. As you see in this pyramid, evidence of pyramid, the best is really randomized clinical trial. On the top is systematic review on meta-analysis, followed by randomized controlled clinical trial, cohort studies, case control studies, case series, case report, and so on. So as you see, descriptive studies are at the bottom, then cohort, then analytical studies, then we come to the interventional experimental studies, and on the top notch is the systematic review and meta-analysis. In summary, case series is a coherent set of cases of a disease. That's it. In a population studied at a specific time and place, we call it cross-sectional. Always the primary output is prevalence data. Though association between risk factors and disease can be generated because we are looking for both exposure or outcomes. So we can talk in cross-sectional study about association between exposure and disease, but not causation, not at all. Do not use the word cause in once you are discussing the results of your cross-section. Case control studies, we know the outcome, we look for the exposure. We select based on the disease, we want to know what are the risk factors. In cohort, we know the risk factor, but we want to follow up to look if they develop disease or not. In a population of study are divided in two groups. If the population of study is divided in two groups and the investigator impose a health intervention, the design is a trial. So in conclusion, it is the well-defined research question that dedicate the study design. Not that every study should be a randomized clinical trial because it's the gold standard. The proper use of evidence-based information is not the strict adherence to only randomized clinical trial, but more accurately, the informed and effective use of all types of evidence. Thank you so much, and I hope you really enjoyed this too much knowledge and information in this 1-hour presentation.
Thank you, Dr. Attanir. Thank you so much for your outstanding and informative lecture. Sorry, there is no time to direct questions of attendee to Q&A as we run out of time, and we have to move to the next session. But as I promised, we will reach you with the answer either through email or WhatsApp. Thank you again, Dr. Attanir. It was really our honor to be with us today. So in a few minutes, we will move to the next session. And thank you all for your attending, participation, and listening. Thank you.
Thank you.
Welcome back, everyone, and sorry for this very short break. Now it's a great honor to introduce you, Dr. Ali Hassan and Dr. Manal Al-Muallim. Dr. Ali Hassan is diagnostic radiology resident at Sulaimaniya Medical Complex in Bahrain. He completed Doctor of Medicine with honor from University of Jordan.